Hello, I'm Ann O'Day from the University of Kansas Cancer Center, and I have the pleasure of moderating today's tumor board. We have a very esteemed panel of individuals today with us, and so I'm going to ask them to each introduce themselves.
Hi, I'm Norman Womark. I've been around for a good many years, as perhaps some of you know. I'm chairman of the NSABP Foundation and one of the chairs for NRG Oncology and the contact PI for that group. And I'm professor of surgery at the University of Pittsburgh.
Hi, I'm Tom Buchholz. I'm a breast cancer radiation oncologist. I'm the medical director of Scripps MD Anderson Cancer Center and professor emeritus at MD Anderson Cancer Center in Houston.
Hi there, I'm Sarah Hurvitz. I'm at the University of California, Los Angeles, Johnson Comprehensive Cancer Center. I'm professor of medicine and director of the breast oncology program there.
Hi, I'm not going to tell anybody how long I've been around, but I am the director of imaging at the Evelyn Lauder Breast and Imaging Center at Memorial Sloan Kettering Cancer Center, and I am primarily a breast imager, but I also do PET imaging as well. So if I come on a PET scan, it does come with a little bit of experience in the background. I am a member at Memorial, which is the equivalent of a professor, and a professor at Cornell Weill as well.
Thank you so much to all of you for joining us today. I look forward to learning from each of you. This is a 65-year-old woman with clinical stage 2B invasive ductal carcinoma of the left breast, ER/PR positive, HER2 negative, and this patient has a known BRCA2 mutation. And so we're going to discuss her, among other things, the choice of systemic therapy. So this is a patient that self-palpated a left breast mass in the upper outer quadrant of her breast. She has a good performance status of 0, a little bit of hypertension and osteopenia, otherwise no significant medical history. Family history, notable for a mother with breast cancer in her 50s, a paternal cousin with ovarian cancer, and one of her half-brothers with prostate cancer. Also a paternal cousin with prostate cancer. And we'll go ahead and let Dr. Jockelson review her mammogram for us.
Okay, so I only have the single image of a spot film of her breast, which demonstrates a spiculated mass, and you can see that there are associated microcalcifications in that mass. In terms of what is reported here, she's also had abnormal axillary lymph nodes. What I would suggest, if she hasn't had this, first of all, I'd be magnifying the calcifications to look at the true extent of disease. And since she's a mutation carrier, if she hasn't been having MRI, she definitely requires a bilateral breast MRI. So that's.
Thank you so much. So the biopsy ends up demonstrating a grade 3 invasive ductal carcinoma, estrogen receptor strongly positive at 98%, progesterone receptor 24%, HER2 negative, 1+ by immunohistochemistry, and FISH negative with a ratio of 1.4. Her Ki-67 was 32%, and she ended up having a FNA of the left axillary lymph node, which appeared suspicious by sonogram, and this was positive for metastatic carcinoma. So I might ask Dr. Hurvitz, based on all of the recent data from San Antonio, and now that we know we have a patient with lymph node positive disease, hormone positive, but also lymph node positive, how would you approach this patient in terms of thinking about her systemic therapy? And would you be looking at a neoadjuvant approach, and would you be looking at genomic testing kind of upfront in your decision making?
So this particular patient who's lymph node positive with a high-grade tumor, I do think it's important that she undergo staging scans to ensure that there aren't distant metastases at this point. We know she's a BRCA2 carrier and has a high expression of ER, but relatively low expression of PR with a high Ki-67. If we didn't have genomic assays, I think, 10 out of 10 clinicians in the room who treat breast cancer or deal with breast cancer would be able to correctly predict she's going to fall into a high risk category. So I would be very surprised if a 21 gene recurrence score or a 70 gene score came back as low risk given these clinical features. I think chemotherapy, in spite of the fact that she is 65, and so we know chemo benefits women over the age of 50 or postmenopausal women less so than younger women, but I do think that chemotherapy is going to end up being warranted here. And similar to, the last case, I think, an anthracycline taxane-based approach should be discussed here, assuming that this is a lymph node positive disease. I think the FNA was positive. In terms of the neoadjuvant setting, as we discussed earlier, neoadjuvant therapy, be it chemotherapy, endocrine therapy, or endocrine therapy plus a CDK4/6 inhibitor, yields very poor pathologic complete response rates for ER positive, HER2 negative breast cancer. Norm quoted earlier, 15% or so, and that's for grade 3, which hers is, but it is an area where we are not good with our systemic therapy in terms of being able to achieve a path CR. So the situation where I would use neoadjuvant systemic therapy is if we needed to make the tumor smaller to improve the surgical approach and outcomes. And in the COVID era, particularly where I'm from in Los Angeles right now, all of our operating rooms have shut down to emergency cases only because things are so severe. So I would bring that up as another reason to start a systemic therapy approach if surgery is needing to be delayed.
Thank you so much. And just to ask, does her BRCA status, would that influence at all your choice of systemic therapy?
That's a very good and controversial question. In patients who carry BRCA1 or 2 mutations, we have a handful of studies that indicate adding a platinum to the regimen will improve the chance of pathologic complete response, possibly even improve disease-free survival, although that's been inconsistent in clinical trials. Where I will usually incorporate a platinum, quite honestly, is in the neoadjuvant setting for triple negative breast cancer that's BRCA1 associated. But again, that is not necessarily standard of care. There's a lot of, as I said, controversy in this realm without really consistent data in terms of how much that will benefit a patient in the long run, whether it will.
Perfect. Thank you so much.
Well, of course, we have to raise the issue of PARP inhibitors there.
Absolutely. And I think we have a great NSABP clinical trial evaluating an adjuvant use of an adjuvant PARP inhibitor. And certainly if she did not achieve a pathologic complete response, that might be a reason to do neoadjuvant systemic therapy to qualify her for a clinical trial looking at a PARP inhibitor. Right now, we don't have PARP inhibitors available for non-metastatic breast cancer, but I'm looking forward to seeing data from the ongoing studies evaluating these drugs. And actually at MD Anderson, Jennifer Litton had a very, very lovely study looking at BRCA mutated patients using neoadjuvant PARP inhibitors with very decent pathologic complete response. And I may be incorrect, but I think it was only triple negative breast cancer enrolled in that study, but don't quote me because I don't have it in front of me and I can't recall.
Thank you for that. And thank you.
So we're waiting for Olympia, clearly.
Yeah.
That should be elucidating because brightness was not targeted for HER2 for BRCA somatic mutation and genetic ones.
Thank you so much.